So advanced care planning is something we've been hearing about possibly a little bit more in 2020 because of COVID. Um, and has motivated a lot of people to get their directives completed. But it is a process. And the process is learning what advanced care planning is, what it involves, and considering it ahead of time. One of my favorite sayings, and something that I say all the time, is it's better to have these conversations around the kitchen table than it is around the ICU bed. And then letting other people know your preferences. Another one of my favorite sayings, I have lots of them, by the way, and lots of stories, is 80% of the process of advanced care planning is having ongoing conversations about your wishes. 20% of it's actually doing the documents. So why do we do advanced care planning? What are our goals, and why is it important? Well, it's been shown that advanced care planning shows a better quality of life. That's part of the outcomes. Reduced psychological distress and reduced intensity of care, or type of care at the end of life, if that's what someone's wishes are. This slide usually gets a few chuckles, and rightfully so. We tend to be a society that doesn't like to talk about death and dying. We're a little death averse. And unfortunately, the vast majority of people haven't talked about or put in writing their wishes for medical treatment at the end of life. And very often that means that families don't know what their loved ones' wishes are and may have to make some really difficult decisions. It's very often when I talk to groups that people share with me the experiences they've had, and maybe with a grandparent or an aunt or an uncle or a friend, where people did not know what the wishes were, had not named an agent, and it caused a lot of family strife, a lot of guilt, and a lot of anxiety after the person had passed. So it's very important for us to say, how would we want to live at the end of our life? It's not so much about the dying process, but it's how do we want to live at the end of our life? So that means people need to plan for the unexpected or plan for the expected. So what if you had an accident and you couldn't speak for yourself? What if you were unconscious and a family member or a boyfriend, girlfriend is called to the hospital? How will they make decisions? Many of us have grown very familiar with HIPAA privacy rules. And if you do not have your person named to be, I'm going to use these terms interchangeably throughout the presentation. If you don't have somebody named to be your healthcare advocate, agent, or proxy, you can use all of these terms pretty interchangeably. If you don't have that person named on your medical durable power of attorney in the state of Colorado, we're going to talk in a little bit about how difficult it is for those people to get information, make decisions for you. It's just a very important thing to do. We spend a lot more time making plans about, well, before COVID, where we'd go to dinner, or about our vacations, or if anyone's ever planned a wedding, or even planned for our retirement. We spend a lot of time planning for that, but we don't always plan for that inevitable end of life. So we want to make sure that we do that, and it's a way to take care of those people that we leave behind and that we love. So how do we do that? Well, we do it through having really good conversations. Conversations, once they get started about what your wishes are, should be ongoing. Through our program, we use the Conversation Project. The Conversation Project is a wonderful nonprofit that was started back in the early 2000s by Ellen Goodman. And Ellen Goodman was a very well-known Pulitzer Prize-winning Boston Globe columnist. And she had the opportunity to become passionate about this through her own experiences. Her mother was on a dementia journey. She was an only child, and she realized, unfortunately too late in that process, that she and her mom hadn't had good conversations about what her mom would want. And she was left having to make all of those decisions. Well, she started talking to her friends and her family members, and everybody had had this experience. So she started the Conversation Project. This has been such a valuable resource, not only for the Conversation Starter Kit, which is one of the tools that we use in our program, but also they came out with a great conversation kit for what would you want if you contracted COVID. And so I also have COVID related resources, and that conversation kit is on our website. When I do a one-on-one session, and lately I've been doing a lot of those via Zoom and actually sharing my screen and walking people through the process, but I also, if people aren't able to, we do limited one-on-one appointments. I use these tools to help people think about the questions that they need to ask themselves and the questions that they need to go over with their family members. Because sometimes you can have those conversations and you think, oh, yeah, we covered everything. I know they know exactly what I would want. But I will tell you, very often, after people see the Conversation Starter Kit and think about it a little bit more and use it as a tool, they say, wow, I never even thought about that, but that's really important. Our program is really focused on being human-centered and relation-centered in decision-making. So you want to give your loved ones the flexibility to make decisions for you, because we can never fully know exactly what kind of situation they're going to experience. So conversations are important, but sometimes there's some real barriers to having those advanced care planning conversations. The number one that I run into, and I've been doing this for a while, I did this when I was an administrator as well, because people didn't talk enough about advanced care planning, is a lack of awareness. And a lack of awareness is to, there's a process to do this. This is something I need to do when I turn 18 because people need to know what I want. People are really not aware of it. And we've done education to close to 20,000 people in Northern Colorado since our program began in 2016. Also denial. You know, remember that slide I showed you at the beginning about 100% of people are going to die? There's a few holdouts that are in denial that they're going to be part of that 100%, because we are rather death averse. And there's a real lack of death and dying education in our society and the comfort in talking about end of life. There's also a lot of confusion. There's confusion about what's palliative care, what's hospice care, how does that conflict with everything else? Who needs to have advanced directives? Do I just need advanced directives if I'm seriously ill or if I'm an advanced age? I have a slide at the end that actually talks about what's the difference between palliative care and hospice care. There's also cultural differences, and there's racial, ethnic and religious beliefs that play a role in advanced care planning. And by completing advanced directives, it helps to promote health equity by having a really clear definition of what people want for medical care. So what are these advanced directives that I'm talking about? Well, I'm going to talk about the 4 that my program deals with. The number 1, and I always say this is the most important one because it's your medical durable power of attorney. This is the form that names the person that will speak for you. So as I said, sometimes that person is called an advocate. In the state of Colorado, legally they're called your healthcare agent, and in some states they're called a proxy. The next I'm going to touch on is the living will, which is used at the end of your life if you're terminal or in a persistent vegetative state. I'm going to talk a little bit about the CPR Directive and about what we have in Colorado called the MOST form, which is a medical order for scope of treatment. All of these forms are available with a lot of education at our website, larimeradvancedcare.org. So let's start out by talking about the medical power of attorney. This is the document, and our version of it meets all Colorado state statutes and is only 1 page. It designates who will make medical decisions for you if you are unable to. So that is you appointing a primary agent. The primary agent's able to consult with physicians, view medical records, and make decisions related to your healthcare. They must be at least 18 years of age and should be someone you can trust to carry out your wishes. So when you're choosing your agent, you need to look for the following. When we talk about age, 18 years of age, we always say preferably 21. It's a lot of responsibility and can be a lot of stress to be a healthcare agent. Someone you can trust to carry out your wishes. If it's a person that maybe has different philosophical views or religious views, that can sometimes cause conflict when it comes down to carrying out wishes. Someone that knows you well. Maybe your great niece Judy is not the best person because you haven't seen her since she was 15. So maybe it would be your best friend that you've known forever. Someone who can reassure and communicate with the family. This is where those good conversations come in, and they should be conversations about who you choose to be your agent and why you've chosen them to be your agent. Someone that will ask questions and advocate to doctors. Somebody that's calm in a crisis. If you have someone that absolutely freaks out when there's a stressful situation, maybe that's not the right person to choose to be your agent. But if they're calm, and I'm going to show you a video here in just on the next slide that I think is a kind of a lighthearted look at choosing your agent. And it should be somebody that understands and will respect your wishes. And so you're going to see a little bit of each of those in the next slide. All right.
Be your healthcare proxy? Like if you need someone to tell the doctor what to? I just go with whatever the doctors say. I wouldn't want to bother them. They're so busy. Doctors know best, right?
Be your healthcare proxy? Sure, I'd be happy to. If I'm in town, check out my Instagram pics from Peru. Wish you were here.
Oh, I could never let you go. I can't even throw a plant away. As long as it's got one little green leaf. I'd be like, can't we upload her to the cloud?
Well, heck yeah. I've given this a lot of thought. Let me tell you what decisions you're best off going with. You never let them resuscitate. And if they even try to hook you up to one of those breathing machines, never. I got this. I totally got this.
How can you even talk about this? I can't, okay? I just can't. Mom, it's not like you're gonna die. No. bleh. And then he's like, wow. Oh, wait, sorry, what?
Well, hon, you and I have been through so much together. Here's what we'll do. We'll sit down, we'll get a cup of coffee, and you tell me what matters to you.
Well, it wouldn't be easy. I mean, I'd be sad, but I'd have your back.
I remember when we went through this with Mom, we really spoke for her. So I think I can do that for you. Let's talk about what you would want.
Oops, sorry about that. So I hope you enjoyed that video. That was courtesy of the Conversation Project. And I think does a really good job of talking about who would be the best person to be your agent. And you can see, doesn't necessarily have to be family. It can be anyone that you trust to make those decisions. So an agent literally steps into your shoes. When I first started this program, we worked very closely, and we still do, with the medical community here in Northern Colorado. And there was a physician who was a hospitalist, meaning she worked in one of our major hospitals here in Northern Colorado at the time. And what she said about the authority of an agent and that agent stepping into your shoes was very impactful for me. She said that as a hospitalist, as being a physician that works only in a hospital setting, if she's assigned a patient, she doesn't know anything about that patient. And if she walks into the ICU and the person is unable to speak for themselves, she only knows them by what's in their chart, what's in their medical records, what are the results of their latest diagnostic tests. And she said, when someone steps forward and says, this is my mom or this is my best friend and I'm their healthcare agent, she said, all of a sudden as a physician, it feels like a weight has been lifted off her shoulders because that person that she's taking care of actually has a voice. And that's how important a healthcare agent can be. So not only to you, but actually to those in the medical community that are treating people. So what happens if you don't have a medical durable power of attorney? Well, I'm very lucky. I come from a large family and I have lots of nieces and nephews, and so I get lots of really good stories. So this story happened to one of my family members' spouses back in 2016. So about 6 months after our advanced care planning team was formed. So what happened was this family member, spouse of my niece, was really excited because he's gotten this old 1964 pickup, and it was his dream model and make, and wasn't running, and it was going to be his project to get this pickup fixed up. And he'd been working on it for about a month when we had one of those beautiful November days, and he was out working on the pickup, and his head was underneath the hood, and he had my great niece, his 21-year-old daughter, go ahead and start the pickup. When that happened, it did what's called flash, meaning it caught on fire. It burned his face, his chest, and his arms very severely. And he was rushed to PVH. When he got to PVH, they made the decision that they weren't able to treat him there because he needed a higher level of care. And so they were going to use the Flight for Life helicopter and take him down to Anschutz Burn ICU. When they got him to the hospital, they did what they called intubated him. So they put a tube down his throat, and they also, because his pain level was so high, they went ahead and pretty much knocked him out. When I got to the emergency room, my niece was, of course, very upset. But one of the first things she asked me is, what's going to happen? I told him he needed to get in and get his documents done. And at the time, I said, well, we're not going to worry about that. We'll just go down to Denver and we'll go from there. But in my mind, I'm thinking, uh-oh, this could be a really bad situation, because this was not a first marriage for him. And he had 3 adult children from his first marriage. He had my niece, who he'd been married for 22 years, a 21-year-old daughter, my great niece, and he also had a mom and 2 brothers. So under our proxy decision maker law here in the state of Colorado, all of those persons would have been considered interested persons who would need to be informed of the patient's lack of decisional capacity. And all of those people would have tried to reach consensus as to who would make medical treatment decisions. And I draw your attention to the bottom. So even his spouse is on the same level as all those other people when it came to voting for the proxy. Luckily, within about 36 hours, they were able to take the tube out, and he woke up enough to do a verbal designation of his wife as his healthcare agent. But you can see in a situation like that, this could have gone very, very wrong. And this is why I tell people it's so important to just do that one document, that medical durable power of attorney, because you don't want to have a situation where a family can be literally torn apart. So now we're going to talk just a little bit about the Colorado Living Will. Many of us are very familiar with the term living will, and oftentimes it's kind of like an umbrella term that we use for all of our advanced practice. But the living will was actually brought into being by, some of you may have remembered hearing about the Nancy Cruzan case many, many decades ago, where that was a Supreme Court case. And we've also had other cases around end-of-life decision-making, like Karen Ann Quinlan and Terry Schiavo. Well, the living will really does talk about those situations. So you'll remember that I said the medical durable power of attorney is so important. And one of the reasons it's so important is because it can be used many times in your life, kind of like the workhorse of the advanced directives. So for example, I got to have back surgery in April. And while I was in surgery and right after recovery, my medical durable power of attorney was in place. And my agent, who happens to be my husband, was the one that was actually speaking for me. But as soon as I woke up and I had capacity to make my own decisions, just like my niece's spouse, then that went back to me being able to make my own decisions and voice them. The living will is only used at the end of your life. So in order for the living will to be used, and most often, quite honestly, it is used as a guide, it does cover the withholding or withdrawal of life-sustaining procedures if both circumstances are met. So if there's no hope of recovery from illness, and that can be a terminal condition or a persistent vegetative state, and you're unable to make your own decisions. So it talks about life-sustaining treatments quite often. Those are treatments around breathing treatments, like if you were on a ventilator, which has been a big concern during the time of COVID. It also talks about artificial nutrition and hydration. So it's important to understand that this is a document that's only used at the end of your life. So I like to interject a little bit of humor in a rather heavy topic. So just so you know, I want to live in a vegetative state. I never want to live in a vegetative state dependent on some machine. If that ever happens, unplug me, okay? She says, okay. And as she unplugs the TV, he says, hey. So that's kind of a little bit of a living will humor. So what is the relationship of a living will with the medical durable power of attorney? There are folks out there, and I meet with them quite often, that we call solo agers, and that's kind of a newer term. They're individuals that do not have someone to name as under their medical durable power of attorney as their advocate, and they prefer to utilize other ways to make their wishes known to the medical community. In a case like that, the living will can stand alone as a directive without agent involvement if the person cannot speak for yourself. I also use tools like the Conversation Starter Kit, or some tools that are a little more in depth. Some people may have heard of the 5 wishes, which is a tool that I use quite often with folks that are solo agers, since it has quite a bit more detail involved. On your living will, you do have the option to allow your agent the authority to either override your wishes that you've put in your living will or not. It's about 50-50 in that situation, where people will say they're going to kind of let their agent go ahead and make those decisions. Other people say, I don't want to be a burden. I don't want the decision making to be a burden, so I'm not going to let them override. It's definitely something that is a preference, one way or another. Everything is individual. In the same way as what you put in your living will. I've had people put in their living will that they want to receive life-sustaining treatment indefinitely. I've had other people that have had other things that they've put in as far as their goals and wishes were. There's no wrong answer. It's your document. So you can put anything in there that you want, except that you don't want CPR. So in the state of Colorado, there are the other 2 directives are your directive to withhold cardiopulmonary resuscitation, or CPR, and your medical order for scope of treatment, or your MOST form. If you do not want CPR, if you do not want someone pressing on your chest, as they show in this picture, or intubating you or shocking you, then you would need either one of these documents to let first responders and the medical community know what your wishes are. So, CPR directive is signed by you and your doctor, and it does tell medical personnel what to do, what to not do if your heart stops or you're not breathing. I always tell people that if you decide that you want a CPR directive or a medical order for scope of treatment that says that you do not want CPR, that you make sure that you get CPR jewelry. And I really suggest that people get CPR jewelry, that they get a necklace, because that's the first place people are going to look. So if you're shopping at King Soopers or Target and all of a sudden your heart stops or you're not breathing, and that big burly off-duty firefighter comes by and wants to do CPR, he's going to see your CPR directive, your jewelry, your necklace that says no to CPR. And I have information about that. It includes not using breathing tubes, electric shock, or pressing on the chest. This is something that people get confused about, because CPR becomes a do not resuscitate order for the duration of a person's stay in the hospital. So CPR directive and do not resuscitate order are the same thing, but in a hospital, you'll see that DNR bracelet. The CPR directive in the most form, I can't stress enough, are doctor's orders. So they're a set of medical orders and they must be signed to be valid. So the CPR directive cannot be changed by the healthcare agent. However, the most form can be. So for people that don't want CPR, they may want to do a medical order for scope of treatment. Some of you may have seen a medical order for scope of treatment. It's a bright green form, and that's so that it's easily recognizable if someone wants to keep it on their refrigerator, so that if first responders are called to their home, it will be something that they look for. The most form is appropriate for individuals that have a serious or terminal illness or are of advanced age and may reside either at home or in an assisted living or skilled nursing facility. So I like to say, if you're a healthy 65-year-old and you still want to have CPR and your doctor gives you this on your initial Medicare physical, you may want to talk to them a little bit more in depth about that, because the most is really for folks that don't expect to still be here in 2 to 5 years. So very important that the most is a form that really designates whether or not you want CPR and also what your goals of treatment are. So your goals of treatment can range from full treatment to comfort care only. And this next slide I put in just so that I could illustrate a couple of different options at end of life. I get a lot of questions about what's palliative care and what's the difference between palliative care and hospice care. So I came up with a slide to help people look at it and see what they have in common and also how they differ. So there's many misconceptions about this, but the number one thing that you have to remember is they both really work at providing comfort for the individual and their families and reducing stress. So palliative care is a little bit newer term to a lot of folks. We've heard about hospice. Hospice has been around for a very, very long time. But palliative care is a little bit different. And it is really starting to be a very valuable way to deal with folks that are at any stage of a serious disease. And it's based on need. Let me give you an example. At the Harmony Cancer Center, they now have a palliative care team. Because palliative care can be provided at the same time as curative care. So someone can be in the palliative care program and they can be receiving radiation or chemotherapy or other treatments. It is paid for by insurance or it's self-pay. And it used to happen just typically in a hospital setting, but it's becoming more and more typical to have it in an outpatient setting. And some of our hospice providers here in Larimer County actually provide a palliative care consult as well. So palliative care is a team approach and it's very holistic. They look at the whole person and they also look at the caregivers and their loved ones. So what is hospice care? Well, with hospice care, you have to have a prognosis of less than 6 months of life. It does exclude curative treatment. So when you go into hospice care, the hospice care team and the hospice doctors take over and their focus is on comfort and pain relief. It's paid for through Medicare, Medicaid, and most insurances. And Hospice can happen wherever a patient calls home. So it can happen in your own home, it can happen in a family member's home for you, it can happen whenever you're in an assisted living, a skilled nursing, and independent living. So they have in common, they have comfort care in common, they do reduce stress. They definitely offer complex symptom relief related to any serious illness or illnesses. And they offer physical and psychological relief, both to the patients and the caregivers, which I think is very important. So advanced care planning, it's not like a one and done. That's the one thing I want you to remember. And obviously my math was really off because I have 6 Ds instead of just 5. I apologize. So when should you do advanced care planning? Well, if you've never done it before, you should do it now, and you should call me immediately. But you should do it when you reach a new decade in age. You should review your documents. If you have attorney-generated documents, definitely take the time to go back through them. Many times I'll be doing a presentation and someone will say, oh, I did my documents 30 years ago, got them all done. And I say, well, have you looked at them? And they said, gee, no. And now I'm in my 70s or 80s and some of my wishes may have changed. So you can do a revocation on your medical durable power of attorney at any time. Sometimes if you've experienced the death of a loved one, maybe that loved one was your healthcare agent and you need to make sure you have a new one. Or maybe some of the people that you've named on your documents in the past have experienced some health issues of their own. Definitely when you divorce. In the state of Colorado, if you're legally separated or you're divorced, then, and you've named your ex-spouse or ex-partner on those documents, then you need to make sure that you redo those documents. You can always, after your divorce is final, many times, surprisingly, people have put their ex-spouses on there as their primary healthcare agent because they say that person, I may not want to live with them anymore, but I trust them to make good decisions for me. If you're given a diagnosis of a significant medical condition, it's very important to review your wishes at that time or make sure that you get them done. If you have a decline in medical conditioning, it's very important. If you're departing for a trip or moving locations, it's always important to look at your documents. So, in summary, it's really important to think about your values and your desires and your wishes. Have really good discussions with your loved ones. Start to have the conversation. You can have that conversation anywhere. It doesn't have to be around your kitchen table. I've heard a lot of people during COVID actually getting their family members in a car and going on a road trip and having discussions about what their wishes would be. Write down your wishes via the Conversation Project booklet and through advanced directives. Discuss them with your primary care physician. And then it's important, and this is one of the things that I do for folks, is once we get your documents completed, I have the ability to securely share those with both UC Health and the Banner Health System here in Northern Colorado. So they become part of your electronic medical record. If you're on UC Health, they'll also show up in your My Health Connect patient portal, which is really valuable to have. So it's about conversations and it's about wishes. And it's about how we care for each other. So see, that's how it's supposed to happen. You're all sitting around. I have a really good friend who was an ICU nurse, critical care nurse for a long time. And she told me that every Thanksgiving, when her family is all together, between the main meal and dessert, she makes everybody go around the table and talk about their advanced directives and make sure nothing has changed in the last year, which I think is a great idea. It's like no pumpkin pie and whipped cream until you've had these good conversations. So you can get a hold of me through, it says contact us, I'm a team of one, but I have some great volunteers. So our website is larimeradvancedcare.org, and we're located, my office is located here at the Health District building. I am available to do one-on-one sessions, or I do group presentations. You can tell I just love to talk about advanced care planning. And I just wanted to plug a couple of things that we have coming up. If you know of anyone that might be interested, on December 8th, in conjunction with the Aspen Club, which is one of our community partners, along with Columbine and UC Health and Banner, we are going to be doing an advanced directives presentation. It'll be a little more in depth than this one. December 8th at the Fort Collins Senior Center from 9:30 to 11. We're hoping that we know that it'll be in person, of course, socially distanced and masked, and also live streamed if possible. In January, I will be hosting a Death Cafe, which is just an opportunity for people to get together and talk about end of life. And that'll be January 7th at 10 a.m. at the Fort Collins Senior Center. Every third Wednesday of the month at 3 p.m. In partnership with the Old Town Poudre Library, we have a great group called the Book Club for Mortals, and it's an ongoing group. We currently meet via Zoom, and we focus on books dealing with end of life, and we have great conversations and lots of laughs. So that's it. Allie, did we have some questions?
We had a couple. One of them you answered already. I was just impatient.
I'm glad you had questions.
The first question I got is, how do we find an appropriate lawyer for medical powers of attorney, one who's not too expensive?
Well, I'm happy to help folks with medical powers of attorney, but if you're looking for attorneys to help you with simple wills and financial power of attorneys, I really encourage folks to, there's a couple of different ways. Through the Larimer County Office on Aging resource guide, they have a list of elder care attorneys, or you can go to the Larimer Bar Association. And I encourage people to shop around and just ask what folks charge and that, how that goes. But through your resource guide through the Office on Aging, they do have a list of elder care attorneys, and they also have the number for the Colorado Law Project, which is legal services based on income. Any other questions?
Yes. Can you designate a primary and a secondary agent for your medical power of attorney?
Oh, great question. Yes. You can do a primary agent and up to 2 alternate agents.
Right. And how do medical powers of attorney and living wills work in other states and other countries for when we can actually travel again?
Yes, hopefully that'll be soon.
Yeah.
So what we really encourage people to do is to make sure that their documents are witnessed and notarized. So in the state of Colorado, under our Colorado statute, it is optional to have your medical durable power of attorney witnessed or notarized, and your living will must be witnessed. So what we try to do, if at all possible, is to make sure those documents are witnessed and notarized, because it does make them more portable across state lines and out of the country. but there's a 50 different advanced directives, but they're fairly similar, and most states will accept a Colorado advanced directive.
All right. And is that one witness or two, or does it matter?
It's 2 witnesses. So what we've been doing a lot in the age of COVID is a couple of different things. One of the things that I do and our program has done is we do what we call employee campaigns. So an example is at CSU, we've done a lot with housing and dining, the vet school, and some other of the colleges. But I just finished doing the city of Fort Collins, our 3rd year of doing an employee campaign. So doing that in the summer, in the middle of COVID, we didn't really have a lot of opportunities to do one-on-one sessions where we got everybody's documents witnessed and notarized. So I've had a lot of people get pretty creative. So you can do notary services at like a UPS store, or you can do notary services if you have a good relationship with your bank. I've had a lot of people that said, well, I won't do the notary, but I can have my neighbors witness me signing it and then leave it on their front porch so they can witness it and they can watch me outside the door. And then they go ahead and scan those documents to me, and I'm able to, along with the release, and I'm able to share those with both of the health systems. So we're getting pretty creative at doing this digitally, but I am doing some limited one-on-ones here in the office. Have my plexiglass and my sanitizer and everything you need to go ahead and get your documents done here as well, if that's too hard to get them done otherwise.
Just got another good question. Do you have any advice for a young person to talk to their parents about advanced care planning? My parents are pretty stubborn and they think they don't need advanced planning.
Oh, of course I do. I even have ways to start the conversation. So part of the conversation project, and I really encourage you, you can definitely go to my website and go to, let me get to that again. You can go to my website and you can get all of those resources off of my website, including how to have the conversation. There's some great videos, but I can also help people one-on-one, and I sit down with people and I go through the Zoom process, even if they're really hesitant to talk about advanced care planning. I always say it's never too early to do this until it's too late.
Right. Awesome. Any further questions? If you want to unmute, that's fine.
Is there any data coming out as to how many of the people who died from COVID already had advanced care directives in place?
You know, I honestly can say I have not heard, and I'm very connected with the with CTAC, which is the Center for Terminal and Advanced Illness, and National Health Center. I know just anecdotally, I can tell you that there were a lot of people that did not here in Northern Colorado. There, especially from what I'm hearing in Weld County, there was a real lack of folks, especially folks that are predominantly Spanish speaking, having their advanced directives completed. So there's been a big push, and also the library was kind enough to do an advanced care planning video in Spanish and have it on their website. We also have it on our website, really encouraging folks to get their advanced directives done, because unfortunately that was a community that was hit very, very hard with COVID, especially in Weld County. So, but all over. Unfortunately, there's not nearly enough data around advanced care planning, other than we know it's important, and when people have it, they have better experiences at end of life. So
I want to thank everybody for coming to our October speaker series. I want to thank Mindy so much for speaking today. It was super informative, and now I need to get my advanced care planning done.
oh, I look forward to it, Allie. We'll set up a Zoom session and it'll be really easy, I promise, and very painless. I make sure it is. There's a lot of humor, and it's a good thing to do, and it's a very adulting thing to do. Thanks so much for having me. I really enjoyed it.